grateful. And convince other people to invite me as well, but for Nigel's reason. So as you may have noticed, Nigel and I are non-identical twins. Over the years, we have been telling each other Jewish jokes, and this is the reason why I'm here. How many jokes? I don't know, 600? Perhaps we should have counted, yeah. So this is my grandmother and her friend, Madame Zax. Would you?
Separated at birth.
It's not, no, it's not the same as all the ones I told last night. This one I didn't tell you. It's number 82. Would you like another piece or slice of Käsekuchen, that is cake? No, Madame Rosenkrantz, I already had two. Not the same. Not 2, 3, but who's counting? And this is the introduction really, because in the car, Nigel and I have been doing exegesis of the Torah. And one of the books of the Torah is called Numbers, and it's all about epidemiology. So it starts about counting. There are 2 plagues, one after the other. There's a hypothesis, which I don't take. I don't buy it. And we can't buy it unless we count, we analyze. But first we describe. And the theme now is discussions we've had, Nigel and I, on a more serious tone on global prevalence of CP. Now, what is global? Nigel taught me that the globe goes beyond New York City. And indeed, I'm going to tell you 2 extreme stories. They're anecdotes and they're so extreme that they can't be representative, but they touched me. So I was in sub-Saharan Africa. I was presented with a child and told that the child didn't walk because the child had CP. And everybody was in awe because I was so pale. And then I took the child in my arms, as I would do, and then I placed the child on the floor, and the child started walking. And that was a child, the mother and people around, who was said never to have walked, just because their doctor had said the child would not walk. And then there is some more culture, and it's more complex than that. And this hardly exists at all. I mean, this is absolutely an exception. And this could happen anywhere. But it's just to remind us that the world is very rich and complex and very close to us. In another of those occasions, I was seeing patients with a professor who was explaining to his students that normally you should leave a child born preterm, and it was, yes, prior to that gestational age, but much before. You should leave that child by the roadside. But we don't do that any longer. And I'm just saying that, even though these stories are not representative, so we have in mind that when we think we have an understanding and an evaluation of situations, the situations are deeper than what we see. So in our discussions, we talked about these extraordinary people. So I remember Bengt and Nigel also, well, worked with them, also had serious conversations with them. And Bengt and other people, and I'm very happy to be in very close terms with Kate Himmelman, who's still doing this remarkable work, started in Western Sweden, of counting, as in the old book I showed you. And they made a story, which we all know, and this is preterm, and they followed up also children born at term, and then the total. These are numbers of CP, rates of CP, and an explanation that was suggested that it was at that level in the 1950s, and then thanks to our excellence and the progress in medicine, that is in obstetrical care and neonatal care, the numbers decreased. And then the number increased again, and the same explanation was given, because we are being so good. And so some children were surviving. And so we heard the story this morning already. So those who were not considered as impaired because they were dead, some of them survived and were impaired. Many of them survived, were not impaired. And so it was. And then in the 90s, in the 80s and 90s, things were stabilizing, and we didn't know in which direction it would go. And you know that not only in Western Sweden, things have gone better, primarily thanks to the children born preterm. Now, CP is not one thing. So we decided again yesterday, Nigel and I and other friends, to keep the description not as a causal diagnosis, but as an invitation to think about heterogeneity, to think about subgrouping that might be relevant to people, to a number of stakeholders, not each one in their silo, but how we put things together. And one big group of stakeholders are the patients themselves and their family. So, another reminder, which we also had, because Nigel multiplied the excuses for helping me those last few days. I must say that I started this journey 2 years ago. Well, there was some interference by the pandemic, and then by Canadian systems and aviation, but here I am. And so in other discussions we had, there was, of course, the idea that in neurodevelopmental impairment, even if you say CP, or if you say ADHD, or you say autism, or you say intellectual disability, these can also be the same person. And so it's very important to consider that within the complexity, and not to say, oh, and therefore it's too difficult. No, it is reducible to things that we can do, hopefully to be helpful. And we need a common language. And in Europe, after the failure of Esperanto, other languages were suggested, like classifications by the group Surveillance Cerebral Palsy Europe, which I have adopted with progressive enthusiasm, even though I was losing categories which I really liked as a clinician, and that is double hemiplegia and Worster-Drought syndrome. But I think that it's more important to be able to share our knowledge, to build more knowledge together. A relatively recent classification suggested by the SCPE is this MRI classification. I think it's important. One thing that may be regrettable is that while a lot of people are around with a lot of enthusiasm and they represent some variation in disciplines, not all the relevant disciplines are represented. And I always find it quite annoying to have no real alternative than work with an instrument that was designed by people who lack the core expertise. They all have the expertise in CP, but I think that interdisciplinarity also retains the disciplines. And so ideally, I would like more neuroimaging people involved in neuroimaging. And the same could be said about other things. But at least this helps us reason and make more sense of the heterogeneity and move from the causal considerations, which may have their importance, to other considerations, and that is a focus on the developmental aspects, in particular the maturational aspects. It's also important to have functional classification and clinical classifications. And it's interesting to see, for example, that ataxic CP is there. I mean, with many letters in its word suggesting that it's really on par with other categories, but it's really very marginal. And when you look at descriptions, very often you would not find a description of the ataxia pattern. So there are reasons why ataxic CP is a problem in some classification, in some registries, and I'm introducing this term now because I think that really important in generating knowledge. Ataxia is poorly defined. Now, this question can be extended to the rest. Is there a discrete line between all these two? I think that it's good to have questions. We need to use what we have for the moment and work on further refining things. Chimneys. This is Belgium. So I brought a bit of Charleroi for nostalgia, and it's the recognition of specific group like postnatal CP, but also the fact that when we say CP, it's often an entry point into something, but the complexity is very often there. So CP almost never comes by itself. We talked about the clinical presentation, but also more complexity in the presentation, including malformation, including etiologies, causal pathways that we can identify. In Europe and in Australia, there have been encouraging figures, and we can really take a magnifying glass to look better. For example, with birth weights, and I think that there is a lot to say, because any conclusion that we're going to draw can be useful, but we need to know to what we attach it. A rendition of Sol Lewitt's lines there from a number of regions and countries from the world, who could contribute numbers suggesting trends over a number of years. So coming from the world, but then the people who are there now are people representing high income countries, resource-rich settings. This is very true. It is very important. And collecting them together allows us to see where we are and possibly where we're heading, at least in high-income countries. And on the left, you see the pre- and perinatal causes or situations with cerebral palsy, and you see almost everywhere a decrease, and this is from a recent paper by Sarah McIntyre as first author, but really people from all five, I mean, Antarctica was not represented, but all the other continents were there. And the contrast in this figure between evolutions which are not all that clear from postnatal CP. So I think that this is very important, and I was very happy to see this paper. I have to catch time. Yeah, in China, well, in specific settings, and is China one setting? Certainly not, but there are things that can be said about China is rapid progress of a number of things that progress more slowly in the United States, in Europe, and other well-equipped and a place where people are also well-trained. And you see changes and also increases in rates, but these might perhaps reflect this progress if we follow this positivistic take. Now, this is also other friends from Uganda, Angelina Kakuza, and another discussion I had with Nigel. So they pulled the line between the different points, but this is just to have a figure with like rocks and hills, because really these are not the same children. And so do not read that longitudinally. But it is quite impressive to see that a condition which is attributed to something non-progressive shows such differences according to the age of the children who are being examined. And when Nigel and I looked at this, one of the things that we said is that the figures are high. They're higher than in Europe and Australia, but they're not so much dramatically higher than some places even in the United States. But they cannot be read in the same way. And it was very interesting to see in this series that only 2% of the children were born preterm. Does it mean that they're so good and all the children born preterm just survive without CP? No, that was not the topic of the paper. We know that there's very high mortality, and in particular for children born preterm. But we know that the priorities might not be the same, especially as we see a large contingent of the children who had infectious disease, and in particular cerebral malaria. And that has a lot of implications which are very different from what we might have here. Now, when I say we might have here, let's also consider that people move. I say I've been on this journey for a while, but say Kernicterus, we hardly see any Kernicterus anymore. Well, I've seen a few in the last year. One from Burundi, one from Latin America, one from Eastern Europe. But I saw them all in Brussels. And so we also need to take that into account when we talk about global things and global trends. So they say that there is, in this important paper, that there is a decrease of prevalence of CP, which reaches 1.6 in 1,000 live births in high-income countries. This is the figure we have now, and we can talk about a decrease because we have enough registries year after year that allow us to draw this conclusion. In low and middle income countries, we can't talk about a trend yet. But we're starting to have enough registries, and even though they were collected using different methodologies, and I must say that there's a lot of creativity also in the methodologies that are being applied in low and middle income countries, and most of those that I see are actually very appropriate to context, and I think very meaningful and relevant. And you see that the current figure is at least twice as high as in high-income countries. Niger is here, Marshallin is here also around the table, and the question that I asked them is, why is CP prevalence higher in low and middle-income countries? So again, they said the infectious causes birth asphyxia. With this idea, maybe we can address birth asphyxia in some centers the way we think we need to address birth asphyxia. And that has been done in this big study in a number of centers. And the results that we have now are not so encouraging, meaning that we need to think, why not? What is the difference? And the difference is also the difference in context and setting. And so we should certainly work on that further. Why is it declining in high-income countries? Well, we want to say because we are so good and so much better. Possibly, yes. And perhaps we're also better at diagnosing other things. And perhaps we're so good at diagnosing other things, including things that are not CP, like progressive disorders, but we might also think that we're so good as to diagnose things that are CP, but are no longer considered by some of our colleagues as CP because we have one gene that explains that presentation, because we have another diagnosis. So we must take these figures with prudence. Always remember that CP is a descriptive diagnosis. Also wonder what we really mean by an etiological diagnosis. And then getting inspiration from other things. And so these are examples that I discussed with Nigel. Other contexts like ALL or CF, which have been success stories for different reasons, which are conditions that are much less common than CP. So how did they succeed? Can we learn from the success? To simplify things to the extreme, randomized trials with a lot of bold attitudes. That was really very courageous from the people in that world, have made a big difference in childhood cancer in general and in acute lymphoblastic leukemia in particular. And the other one, I mentioned it, is registries. Now, registries, that's a very big issue, and we should think carefully how we make registries, what we're going to consider relevant, and in a world where we don't know where it's going to lead us. So we need to be very good at anticipating. We don't want too many data because we won't be able to manage it. And it's not a question of methodology. It's a question of quality of the data. And we want the right data. So that means sitting together, thinking. And CP, it's very interesting to know about it in order to help people with CP and people around them. And the situation with CP is that we do not have many treatment with a strong evidence-based. And because we think we're so good and so knowledgeable, many of us, including me, don't have this natural tendency to knock on the door of the neighbors and then invite people elsewhere and travel and sit together and think together. I think we need more collaboration. It is not a rare condition, but if we want relevant groups within this condition, we need to make these groups. And even if we make big groups, we won't get to the levels of the big problems of public health that are encountered in stronger literatures, say in adult medicine. I'm reading, I wrote these, but collaboration, yes, is that word that I wanted to emphasize. And this is the final one. Yes, CP is a global issue. Let us not forget it. And even what's happening very far from us concerns us also. It is still relevant, even though it's a construct, like any diagnosis of any condition. It is not only motor, we've emphasized that over the last few days. It is a lifelong condition, and that is what it is. We have tended to become better and better, but there's still open questions. There are new issues. There seems to be an increase in dyskinetic CP. It's not entirely clear why. And especially in the UK, Nigel, where you were born, they're selling those all over the place. So I want to read this message and say, thank you, Nigel.